Now we start talking about diabetes mellitus, which is very common disease, affect more than 10% of population all over the world. In Jordan, maybe more than 25% after age 25, they are suffering from diabetes and pre-diabetes. That is really a major health problem all over the world and in Jordan especially. So we'll talk about definition of diabetes, then we classification of diabetes, etiology, which is only just have a few lines about etiology, then we have how we diagnose diabetes and treatment and management of diabetes. So insulin metabolism. Insulin are secreted in the portal circulation, and 50% are degraded in the liver, and the other 50% degradation, the other target tissue like kidney. Enzymatic degradation follow receptor-mediated endocytosis. The plasma half-life of the insulin is very short, 3 to 5 minutes when you give it IV. Like it's very short, you need to have sometimes continuous infusion, especially in patients with DKA. Don't give it IV push because not cover the whole hour. Only within 5 minutes, 7 minutes, the insulin will be, the half-life will be very short. What's the effect of insulin? We have normal insulin, which is normal physiology. We have effect in the liver, skeletal muscle, adipose tissue. Okay, and so in the liver, we have a glycogen synthesis, increase, enhanced glycogen synthesis, and triglyceride synthesis, and inhibit glycogenolysis and ketogenesis and glycogenesis. Okay. In the skeletal muscle, the glucose uptake will be enhanced and increased, and the protein synthesis also will be increased, and the glycogen synthesis also will be increased. It inhibits also protein degradation and the glycogenolysis. So when patients have diabetes and have deficiency of insulin, all will be this mechanism will be opposite. There is no stimulation for glycogen synthesis, and there is no stimulation for triglyceride synthesis, and there is no inhibition for glycogenolysis. This is in patients with diabetes. In adipose tissue, what happened in that? We have a glucose uptake, and it will be increased, and triglyceride storage will be enhanced, and inhibit lipolysis. But in patients with diabetes, they enhance lipolysis, increase lipolysis. So insulin promote anabolic promotion and inhibit catabolic process. When we have insulin deficiency, patients have diabetes, okay? Either we have type 1 or type 2, then we have leading to hyperglycemia. So we have increased blood sugar in the blood due to underutilization of glucose, or we have overproduction of glucose. So we have two entities. We have hyperglycemia. So patients have insulin deficiency. This will lead to defect in the metabolism of glucose and lead to because of underutilization of glucose or overproduction of glucose. We have increased lipolysis because we have insulin deficiency. Opposite of the physiology of when patients have normal insulin level. We have acidosis. We have increased conversion of fatty acid to keto acid, acetoacetic acid, and beta-hydroxybutyric acid. We have increased plasma triglyceride and low density lipoprotein and decreased high density lipoprotein. Okay. We have hyperglycemia will lead to osmotic diuresis and plasma hyperosmolarity and dehydration, leading to hypovolemia and polydipsia. Okay. So we have polyuria and polydipsia to osmotic diuresis, and patient get dehydrated and losing large amount of fluid and electrolyte by severe hyperglycemia. Depletion of intracellular and whole body potassium. So in patient have developed acidosis, especially in patient have DKA, their potassium will be shifted from intracellular compartment to extracellular compartment, and patient have either serum potassium could be normal, low, or high, but total body potassium will be depleted. How we define diabetes? Diabetes is a group of metabolic disease characterized by hyperglycemia, resulting from defect in insulin secretion, insulin action, or both. In type 1, we have insulin deficiency and absolute insulin deficiency. In type 2, we have two entities. We have insulin resistant, leading to hyperinsulinemia, and with time, we have beta cell failure, and we have insulin deficiency. So we have two entities from defective insulin secretion and insulin action. The chronic hyperglycemia of diabetes is characterized with long-term damage, dysfunction, and failure of various organs, especially the eye, kidney, heart, and blood vessel. Like hyperglycemia is uncontrolled blood sugar will lead to defect in different organ. Most of the organ can be affected by hyperglycemia and diabetes mellitus. We have what they call Microvascular Complication, increased chance for ischemic heart disease and cerebrovascular accident in these patients due to diabetes, because diabetes is a major risk factor for ischemic heart disease and cerebrovascular accident. And we have macrovascular complication. Patient who have nephropathy, patient have retinopathy, and patient may have neuropathy, patient may have diabetic foot, okay? All organ can be affected by hyperglycemia and diabetes mellitus. So diabetes in the US health impact of the disease. Diabetes is a major health problem and will be the sixth leading cause of death. And with its complication, maybe number cause of death. Lifespan will be shortened by 5 to 10 years, depend what age patient develop diabetes. The younger, will be more harm, and patient may lose about 10 years. And elderly patient after age 60, 66, 65, patient may lose only 5 years of his lifespan. Renal failure will be 40% of patients on dialysis, they are suffering from diabetes. In this age, patient on dialysis, 40%, they are causes diabetes. Blindness. Commonest cause of blindness after age of 60 is diabetes mellitus. Amputation. Commonest cause of amputation after a trauma is diabetes mellitus. Patients have diabetes have increased chance to develop cardiovascular disease by 2 to 4 times more than non-diabetic patient. Nerve damage, more than 60-70% of patients, they are suffering from peripheral neuropathy or autonomic neuropathy. And the commonest cause of peripheral neuropathy is diabetes mellitus. So diabetes mellitus in the US will be higher mortality risk. Age group between 45 and 64, men, the relative risk about 3.4, and women, which a little bit higher, about 4.6. Between age of 65 and 74, the relative risk will be decreased because lifespan will be shortened. But still in women is more, risk about 1.6 to 2, okay? Over the next 24 hours, what's going to happen? More than 2,000 diabetic will be newly diagnosed. More than 500 diabetic will die. And more than 6 diabetic will go blind. And more than 77 diabetic will be diagnosed with end-stage renal disease. And more than 1 50 diabetic-related imputation will occur. The epidemic called diabetes. And this is from American Diabetic Association. This is what's going to happen in the United States, not over the world, just in the United States. And this map will show the different epidemic through the world. So they are we have about 250 million people in 2007 until 2025 by 55%. Like lifestyle is very important, and exercise and weight reduction is to avoid this increment and increase in diabetes. So this is the global burden of diabetes. In developed country, okay, about 72 million will be about, now we have about 51 million, and 25 will be about 72 million. We have about 90 million, and will be, so the increment will be much higher than developed country. About 230 million, we have about 230 million, and all country, which is developed and developing country. So about now we have about 140 بال95 بال2025 more than 300 million will be suffering from diabetes all over the world. I think this figure will be also much higher than this. So it increased by 41% in the developed country, and in developing country increased by 156%. And all over the world will be, the increment will be about 1.2%. Patients with type 2 diabetes are getting younger and younger because we have change of life in the developed country. So between age of 20 and 44, maybe about less than 5% they are affected by. Between age of 45 and 64, maybe between 2000 2030, we have about تقريبا 20 to 30%, 20 to 30%, okay. Developing country is much higher. Nowadays, 20 to 44, the percentage was in 2000 about 20, and in 2030, which is 2030, they will maybe increase about to 40, okay. Why is diabetic on increase? Ethnicity and family history are implicated. So they run in family, especially special family, like we have Bima Indian, 50% of Bima Indian, they are suffering from diabetes, which is the highest number all over the world, which is the original American, more than 50%. Also Hispanic, or much higher than people with white American, okay? Closely associated with overweight and obese people. Most of type 2, they are obese and lack of exercise. And because of these people have increased switch to Western diet and lifestyle. ما حد بيتحرك, have central obesity, patient eating fast food, and patient have increase in weight, and patients are susceptible to develop diabetes. This is the same, maybe previous slide, but in a different way. Diabetes is a lifelong condition with potentially developing consequence. Heart disease and stroke account for 65% of diabetic-related death. Non-traumatic lower limb amputation, okay? Nervous system damage and diabetic retinopathy. And diabetes is leading cause of kidney failure, 44% of new cases during 2002. Now, what is the criteria for diagnosis? This is very important slide, please, okay? Everybody of you, you must really not graduate from this medical school without knowing how to diagnose diabetes, because it's a major health problem. 25% of our population that are suffering from diabetes and pre-diabetes after age 25. Like we have fasting blood sugar, we have random blood sugar, we have glucose tolerance test, and we have hemoglobin A1C. A1C more than 6.5% or fasting plasma glucose more than 125 milligram or 7 millimole, 2-hour plasma glucose more than 200 milligram, okay, during an oral glucose tolerance test, and a random plasma glucose more than 200 milligram, 11.1 millimole. Like one criteria, a patient are symptomatic, and we have 2 different days measurements if patient are asymptomatic. Like AC more than 6.5, fasting more than 116, random more than 200, postprandial 2 hour after glucose tolerance test, glucose challenge is more than 200. Now we have what they called pre-diabetes or, okay. Pre-diabetes is diagnosed by the following, because normal fasting is less than 100. So between 100 and 125, this cause pre-diabetes. بالأول كنا نسميه impaired fasting hyperglycemia. حاليا بنسميه pre-diabetes. Patient also have a glucose tolerance test more than 2 hour, 200, more than 2 hour, 200 is diabetic. Less than 140 is normal. Between 140 and 199 is pre-diabetes. أو كنا نسميه بالأول impaired glucose tolerance test. The normal hemoglobin A1C is 6, it's 5.7. So 5.7 and 6.4, this is pre-diabetes. More than 6.5 is diabetic. Between here, category 4 increased risk for diabetic pre-diabetes. Now, glycemic recommendation for non-pregnant adult with diabetes. يعني واحد عنده سكري بس مش حوامل، يعني ست مش حامل أو أي رجال عنده سكري. Our aim to keep the hemoglobin A1C less than 7 and preprandial capillary plasma glucose between 70 and 130 and peak postprandial capillary less than 180. So plasma glucose to be less than 180. So this is give you good control. So fasting between 2 hours after food, after meal, less than 180, and hemoglobin A1C to be less than 7. Diagnosis of gestational diabetes is different from non-gestational diabetes. If we perform 70 grams of oral glucose with the plasma glucose measurement fasting and at 1 hour and 2 hours at 24 to 28 week of gestation in women not previously diagnosed with over diabetes. So oral glucose tolerances in the morning after overnight fast at least for 8 hours. Gestational diabetes mellitus is diagnosed when any of the following plasma glucose value are exceeded. Fasting more than 92 milligram. But in normal, which is non-pregnant lady, the fasting more than 126. 1 hour after glucose challenge is more than 180 milligram, 10 millimole. And 2 hour more than 152.3. 8.5 millimole. Any one of these reading, okay, enough to diagnose gestational diabetes. Like fasting more than 92, 1 hour 180, and 2 hour 153. So they are different of non-pregnant lady. How we classify diabetes? The common cause of diabetes, we have type 1, type 2. Type 1 تقريبا what they call beta cell destruction and beta cell failure. 90% of our beta cells are destroyed before patient develop diabetes. It is mostly autoimmune disease, can affect, we have insulitis and destruction of beta cell, okay, and there is positive antibody in these patients. Type 2, we have two entities. You have progressive insulin secretory defect and others. Now we have insulin resistant plus progressive insulin secretory defect and insulin beta cell destruction. So in the beginning, we have insulin resistant. The beta cell try to compensate by production of over insulin, okay? With time, beta cell get exhausted and the insulin secretion start to be declining and then the blood sugar to be going up. So we have two entities, insulin resistant plus beta cell failure. Other specific type of diabetes, genetic defect of beta cell function, genetic defect in beta cell function and insulin action, disease of the exocrine pancreas. So we have chronic pancreatitis or seared pancreas, drug or chemical induced, and we have gestational diabetes mellitus. So we have type 1, type 2, other specific type of diabetes, okay, a genetic defect of beta cell or insulin, what they call moody. سامعين الشباب لأنه بطلع لي my internet is not سامعين؟
سامعينك دكتور كمل.
سامعين طيب شكرا. لأنه بطلع النت إنه ويك نت أوكي. This is the natural history of type 2 diabetes. It's a very important slide. So you see the blue line, which is what they call insulin resistant, okay? And this is insulin resistant. They continue to be because we don't treat insulin resistant. Then beta cell try to compensate by increase, which is the gray line, insulin secretion. With time, and by this increased insulin secretion, they maintain blood sugar with normal range. With time, beta cell get exhausted and failed and destroyed. And then the secretion of insulin decline. Insulin secretion start to be declined. Okay, so then after this decline of insulin, so blood sugar start going up, fasting and postprandial. And then we have complication of diabetes, of course. Beta cell failure is the key event in the development of type 2 diabetes. So beta cell failure due to glucotoxicity. High level of glucose can inhibit the beta cell secretion of insulin due to chronic hyperglycemia. So after we control blood sugar and reduce the hyperglycemia, sometimes they improve the quality of beta cell and patient improve, okay? Oversecretion of insulin in response to chronic hyperglycemia. Beta cell dysfunction and reduced availability of secrete insulin in response to hyperglycemia. And we have lipotoxicity, high level of circulating fatty acid. This is a simple slide of pathogenesis of type 1 diabetes. We have genetic, HLA, DR3 and DR4 are positive. We have environmental factors like viral infection, especially in winter. We have autoimmune encephalitis, which is inflammation of islet cells. And we have beta cell destruction. And then we have severe insulin deficiency. And then we have type 1 diabetes mellitus. And pathology of type 2, we have also beta cell defect and genetic. We have environmental factor like obesity. We have abnormal secretion of insulin and increased insulin resistant. And then we have relative insulin deficiency. Then we have beta cell exhausted, and we develop insulin type 2 diabetes mellitus. Okay. And the past was called non-insulin dependent diabetes mellitus. This is different, which is a simple slide, but really nowadays the life span history is different. So type 1, type 2 was different. The age may be less than 40, but can occur at any age nowadays, type 1. The duration, weeks, but here months to years, type 2. And the age more than 40. Ketonuria common, and it is rare here in type 2. Insulin dependent and dependent. For type 1, there is no place for oral hypoglycemic drug. Treatment equal insulin. Insulin dependent, and then we have independent, autoantibody present, and there's no autoantibody in type 2. Family history maybe is rare in type 1, is more common in type 2. Insulin level, this is the most important element, is very low, and islets encephalitis, okay, we have C-peptide will be low at the same time when we have insulin level is very low. Complication, we have acute and metabolic complication like DKA, okay, and long-term complication. Complication will have late and vascular mostly, increased chance for ischemic heart disease and cerebrovascular accident. What's the clinical feature of patient with diabetes? How patient present to us? We have 4 presentation. First one, which is a classical presentation, every one of you, everyone in the street, they know what's the manifestation of diabetes. اللي هي شرب المي كثير والتبول الزائد وذهاب الحمام في الليل. So polyuria and thirst, okay? Weakness and polyphagia and weight loss. In spite of polyphagia, patient is losing weight. Like مهم جدا, loss of weight with good appetite is need to think rule out diabetes mellitus as a cause. Flaring of vision, vulvovaginitis or pruritus, and we have nocturnal aneurysms, especially in children. Patient was clean, then start to wet himself. Then you need to think about patient may develop diabetes. Young child develop diabetes.
دكتور يعطيك العافية، ضايل أقل من دقيقة للميتنج، نرجع نفوت على نفس الرابط.
سامعك مش عارف الصوت عندي.
ضايل أقل من دقيقة للرابط، فنفوت على نفس الرابط هذا.
نفوت عليه؟
نرجع نفوت
طب
عليه.
ليش حاطينه ساعة احنا؟
هذا
كيف
45
أقدر أسوي شو كيف أعمل شيء جديد؟
على نفس الرابط، لا على نفس الرابط، نطلع منه ونرجع نفوت عليه.
طيب اوكي طيب ارجعوا لنا عليه، انتوا بتعرفوا احسن مني شكرا يا استاذ. So the first presentation is what they call the classical presentation of diabetes mellitus, which is the polyuria and polydipsia and loss of weight in spite of good appetite, and we have nocturia. The other presentation asymptomatic، مريض ما عنده أعراض، بيجي على المستشفى لأسباب أخرى بفحصوا البلاد sugar and they find to be diabetic. And maybe have long-standing diabetes. Like screening for diabetes is very essential and mandatory in patients with high-risk population. مريض بيكون عندهم واحد عنده سكري بالبيت وعندهم جهاز جلوكوميتر بقول لك خليني أجرب بفحص بلاقي 1 300 400 blood sugar. And مريض ما عنده أعراض. And this is other presentation. And the third presentation, which is the acute complication, especially in type 1. More than 30 to 35% of type 1 may present with acute complication, what they call DKA, diabetic ketoacidosis. And patient حاليا for the presentation may present with late complication. المريض معناه عنده سكري at least 15 years and he never knows that he's diabetic. But like screening is very important to know that patient is diabetic, especially in high risk population. Every year حتى نتأكد إنه المريض ما عنده سكري. وإذا عنده سكري to be treated as early as possible to prevent or delay late complication. لكن المريض ممكن يتحول من العيون لأنه عنده روتينوباثي، متحول من الكلى لأنه عنده intestinal disease، متحول من الجراحة لأنه diabetic foot. And this will be unlike a patient. This patient will be suffering from diabetes, long-standing diabetes, for at least more than 10 to 15 years and to develop these complications. بس عمره ما عرف إنه عنده سكري. Like screening is very important for this diabetic patient, okay? حتى نتحايد هذه الأمور، نتحايد this complication. Now, after we diagnose our patient and definitely is diabetic, blood sugar is high, hemoglobin A1C is high, and patient symptomatic or non-symptomatic, okay, then we have to manage this patient with diabetes. So we have diet, exercise, oral hypoglycemic drug in type 2, and insulin in type 1. There is no place of oral hypoglycemic drug for patients with type 1 diabetes. Only lifestyle modification, plus exercise, plus diet, and education. And education is very important. I stress on this point, okay? And education is very important. فمهم جدا. لكن مهم in type 1 there is no place for oral hypoglycemic drug. Only lifestyle modification, exercise, diet, and education plus insulin. We have different type of insulin. We'll come later and mention these type of insulin. And then oral hypoglycemic drug mostly in type 2. Okay, in type 2 we have oral hypoglycemic drug. Diet is the gold standard and cornerstone of treatment of diabetes. In type 1 and type 2, there is no place. المريض بيقول لك أنا باخذ أنسولين خليني أكل براحتي. This is not right and not true. Diet is still the gold standard and the cornerstone for management of patients with diabetes. Diet is the no standard diabetic diet. ما في شيء مكتوب وكل هذا المريض تنطي كل واحد ورقة وقول له كل هاي وما تاكل شيء. This is absolutely wrong. Okay? That must be individualized. بيعتمد على الشخص نفسه. قديش he is young, old, pregnant lady ولا مش non-pregnant lady. And مريض عنده complication ما عندوش. He is overweight, underweight. Okay? Social background of this patient is very important. Patient who's living in Amman, في مش عارف وين, is different. The type of food will be different for somebody who is living with small of our قرانا البعيدة. Okay? وذلك مهم جدا to know what patient eat, which is normal diet for this patient. And tell your patient, by or dietitian must tell your patient to inhibit this food, increase this food, or decrease this food. Okay? ذلك مهم جدا from normal that patient's eating to advise our patient, not to give him list of food. Sometimes he never knows and hear about it, okay? Flexibility and use of ordinary food is important. Diet must be of adequate calorie for maintaining weight or for adult, normal growth for children, and decreased metabolic need in pregnancy. that must contain around 10-20% of protein, 20-30% of fat, and about 50% of carbohydrate. And fiber must be encouraged and increased because decrease absorption of glucose and rapid rise in the hyperglycemia. Treatment of type 2 diabetes. Either we have monotherapy with oral agent, or we have combination therapy with oral agent, or we have insulin with oral agent. And then insulin acquired in about 20-30% of patients. And nowadays, I think we have increased this figure by 30 to 40%. So more we have early induction of insulin is important in patients with uncontrolled blood sugar. With the duration of disease, more intensive therapy is required to maintain a glycemic goal. This slide is very important. This is the group of oral hypoglycemic drug. And everybody must know this group, okay? Because this group, so patient, we have healthy eating, weight control, increased physical activity, and diabetes education. And plus metformin in type 2. Every patient must have metformin if there is no contraindication, which is have renal impairment or advanced liver disease or advanced heart failure. 3 months nitrogen target, which is hemoglobin not reaching 7, then we add other group. The other group, we have sulfonylurea, we have fasediendione, we have DDP4 inhibitor, we have SGL2 inhibitor, and we have GLP-1 receptor agonist, and we have insulin, mostly basal insulin. السلفونيلوريا طبعا they stimulate beta cell to secrete more insulin. like لازم يكون عندنا beta cell functioning cell. And this is cause hypoglycemia. So this medication can cause hypoglycemia and can cause, increase in weight. Thiazolidinedione is insulin sensitizer. It's like metformin. بس الميتفورمين they are يعني weight equal يعني عبارة عن neutral and maybe losing weight. But here they increase in weight. The opposite, they can increase in weight. Like don't give it for overweight patient. And is contraindicated in stage 3 and 4 heart failure. And حاليا maybe increased chance for CA bladder. قبل ما نروح على DDP4 inhibitor بنروح على GLP-1 receptor agonist. GLP-1 هو glucagon like peptide, which is incretin hormone secreted by the gut and cause delay gastric emptying and enhance beta cell secretion of insulin. Okay, these are injectable form like insulin and expensive drug, and can cause weight reduction. But this is the problem with GLP-1, endogenous GLP-1, which is incretin hormone, is the half-life is very short. It is less than 2 minutes. They are destroyed very quickly when go to circulation after assimilation by food by enzyme, what they call DDP4. Like شو عملوا للإنزيم DDP4? They inhibit the enzyme of DDP4. عملوا له inhibition. لما عملوا له inhibition, they prolong the half-life of GLP-1, endogenous GLP-1. صار يشتغل 24 ساعة. Like DDP4 هو الإنزيم destroyed GLP-1. فعملوا DDP4 inhibitor اللي هي منهم فيلداجلابتين وسيتاجلابتين وليناجلابتين. To prolong the half-life of GLP-1. like ما في داعي نعطي DDP4 and GLP-1 إذا بتطلعوا مع بعضهم لأنه ما في أي synergistic effect. SGL2 inhibitor هو عبارة عن صوديوم جلوكوز co-transporter 2 inhibitor. This enzyme is secreted by the kidney and 90% of our glucose reabsorbed through this enzyme. فعملوا له الانزيم inhibition فصار يطلع له جلوكوز بالبول باليورين. فاور جلوكوز they are not reabsorbed and they go with urination. Like they increase chance for urinary tract infection, especially fungal infection with this type, okay? Insulin, cholesterol insulin, which is human insulin. We have different type of insulin, basal insulin, اللي هو بسموه glargine or lantus or levemir, okay? These are two who have basal insulin. Like احنا حاليا metformin plus lifestyle modification, 3-month not reaching target, we add one of these groups. Not reaching target, we add third group or we add insulin. Not reaching target, we stop كل medication and we intensify our insulin. Plus طبعا نخلي المريض على metformin. Was recommendation glycemic blood pressure lipid control in adults. Okay, this is the ADA recommendation. Hemoglobin to be less than 7, blood pressure less than 140/80, and lipid low density lipoprotein less than 180. And if we have other risk factor, less than 70. What's the rationale for normoglycemic lesson from UKBDS؟ الUKBDS هي عبارة عن United Kingdom Prospective Study. study حصل على 15,000 مريض all over the United Kingdom and for about maybe about more than 15 years. And they found out reduction of hemoglobin A1C by 1% can reduce death from diabetes by about 21% and heart attack by more than 15%, and macrovascular complication, this is important, especially end-stage renal disease, more than 37%, and peripheral vascular disease, more than 43%. Like control of blood sugar is very important and very essential to delay long-term complication and maybe prevent long-term complication. For this will be the same, which is the same. هذول برضه non-insulin therapy for hyperglycemia and type 2 البايوجونيد. انا حكيت لكم عن شو البايوجونيد كيف بيشتغل. هو انسولين سينسيتايزر اوكي و its contraindication in patient have side effect هو GI side effect and can losing weight اوكي. فبايوجونيد every patient must take بايوجونيد metformin اللي اسمه التجاري جلوكوفيج اوكي اللي بيسموه مساعد سكري او منظم سكري if there is no contraindication. The sulfonylurea, which is second generation, we have different. In Jordan, we have glabeniclamide, glycoside, and glimepiride. The mechanism of action here stimulate beta cells to secrete insulin. Side effect, hypoglycemia, and increase in weight. Maglinitide هو زي السلفونيلوريا بس short acting بيشتغل أقل. هذاك بيشتغل within 30 minutes, هذا بيشتغل within 15 minutes, okay? They are not much different from sulfonylurea. الثيازودين جليتازون اللي هي نون انسولين ثيرابي فور سو ثيازودين البايوجليتازون بالاول كان في عندنا تو دراج بايو اند روزوجليتازون. الروزوجليتازون شالوه من الماركت دي الامريكان دايابيتيك اسوسيشن لانه انكريز تشانس فور اسكيميك هارت ديزيز اند عباره عن acute coronary syndrome. They improve peripheral insulin sensitivity, no hypoglycemia, increase high density lipoprotein cholesterol and decrease triglyceride, weight gain and edema and heart failure and bone fracture. This is disadvantage and side effect. The GLP-1 receptor قلنا لك هو incretin hormone secreted by the gut and they enhance the secretion of insulin and inhibit secretion of glucagon and delay gastric emptying and suppress appetite. Most side effect here, nausea and vomiting, very bad nausea. And rarely they claim that may cause pancreatitis. And this is GLP-1 modality number, okay? So long-term effect to animal beta cell mass. promote satiety and reduce appetite, decrease postprandial glucagon secretion, and decrease glucagon, reduce hepatic glucose output. على الستومك بيشتغل help regulate gastric emptying. Okay, beta cell enhance glucose dependent insulin secretion. This is the function of GLP-1. A DDP4 inhibitor, which is inhibit the destruction of GLP-1, هو DDP4 enzyme, which is enzyme destroyed GLP-1. عملوا له inhibition. لما صار في inhibition بطل يصير في destruction لل GLP-1. This drug we have sitagliptin, vildagliptin, sexa, and long. Matter here, this drug inhibit DDP4 activity. Action, active GLP-1 concentration, advantage, no hypoglycemia and weight neutral, and disadvantage, occasion of urticaria and angioedema, cases of pancreatitis observed, long-term safety unknown. And this is what the mechanism of action of DDP4 inhibitor. لما يصير ingestion of food, GI tract release GLP-1 and GIP. And this, when they release it, DDP4 enzyme destroyed this and get unactivated. Okay. شو عملنا؟ جبنا سيتاجلابتين اللي هو DDP4 inhibitor and بطل يصير في destruction لل GLP-1 and GIP. Okay. And they prolong the half-life of GLP-1. لما prolong the half-life بيشتغل زي الاكسوجينوس GLP-1. الانسولين is a protein hormone, consists of two long chain peptide, the chain containing 21 amino acid and the beta chain containing 30, which are connected by two pairs of sulfur atoms. Okay, we have alpha and beta chain. Alpha, which is 21 amino acid, and 30, which is beta chain is 30 amino acid. بالأول كنا نستعمل porcine insulin or bovine insulin, but nowadays we use only human insulin. The porcine insulin, they differ on only one single amino acid. Bovine insulin has only two additional substitutions. And this is type of insulin. We have rapid acting, very rapid acting, what they called analog. We have intermediate acting, and we have long acting basal insulin. Okay. الانسولين اللي طبعا الرابid acting بيشتغل within half an hour to 1 hour and duration about 6 to 8 hours and the peak between 2 to 3 hours. Giving sub-Q injection does not produce sharp physiological peak. Give 30 minutes before meal. Very rapid acting insulin, which is like rapid acting insulin, but work within shorter time, with 15 minutes, and duration about 4 to 6 hours, and the peak within 1 hour. Like given between 10 to 15 minutes before meal, not 30 minutes before meal. Intermediate بيشتغل within 2 to 4 hours, and the duration, the peak تبعه تقريبا between 4 to 8 hours, and duration تبعه between 10 to 14 up to 16 hours. اللونج اكتنج اللي هي طبعا gradual بيشتغل زي الجلارجين and ديتامير. They are gradual بيرتفع خلال 15 minutes and they continue to be 24 hours, and there is peakless, no peak, and must not be diluted or mixed with any other insulin or solution. هذه طبعا بتفرجيك الرسومات الليسبرو كيف بيرتفع وكيف بنزل قديش الاورز، والريجولار is more MPH and lenti, then ultra lenti, and then we have glargine and basal insulin. Guideline on dose of insulin. The correct dose of insulin is that which achieve the best glycemic control. The daily insulin dose is 0.5 to 0.6 international per kilogram but daily. The start dose for normal weight patient is 15-20 units. The start dose for obese patient about 25-30 units. 2/3 of the dose in the morning and 1/3 in the evening. 1/3 is rapid acting insulin and 2/3 is long acting insulin, intermediate insulin. Insulin dose depends on many factors like age, weight, the stage of puberty, duration of diabetes, nutritional status, exercise pattern, result of blood glucose monitoring, and intercurrent illness. All this can affect the dose of insulin. Adverse effect of insulin therapy: hypoglycemia, allergy and resistance to insulin, lipohypertrophy and lipoatrophy. And nowadays become rare with the new insulin, which is human insulin. In the past, with the big insulin and cow insulin, it was very common hypertrophy and lipoatrophy. إذا بتشوفوا صور على الإنترنت قديمة for lipohypertrophy and lipoatrophy. Okay. Insulin edema can occur also if giving large dose. This is American diabetic treatment goal for glycemic control. When need glycemia, the average preprandial to be less than 110, average postprandial to be less than 1.6 من نخفف. الجول تبعنا between 80 and 120, and average postprandial to be less than 160, and hemoglobin A1C to be less than 7. Acute complication, this is, I think, need a different lecture. We have hypoglycemic coma, diabetic ketoacidosis, and non-ketotic hypersmolar state. Hyperglycemic hypersmolar state. And diabetic late complication, we have microvascular complication, ischemic heart disease, and cerebrovascular disease, and macrovascular complication, diabetic retinopathy and diabetic nephropathy, diabetic neuropathy, and diabetic foot and dermopathy. Okay, we stop here and we start maybe a second lecture about thyroid.